thank you guys for coming along, and thank you to Diabetes SA for giving me the opportunity to talk. I started out in conventional practice for optometrists in Adelaide here and decided that maybe I'll go try something else, and went and did a lot of work in outreach stuff. Obviously that meant that I dealt with diabetes a lot, probably about 80 to 90% of my patients were diabetic, and often screened through the clinic before they came to me. It was a whole bunch of fun. There was lots of fishing and flying around in little aircraft, so if you ever get the opportunity, go out there. The clinics out there are great, the people are great. And I also worked a little bit in Papua New Guinea, and that was very, very eye-opening. As probably our geographically closest neighbour, that's Australia, that's Papua New Guinea. You could almost get there in a dinghy. Its health system has some things missing, and over there, and granted these numbers are pretty old, but healthcare in PNG I don't think is moving all that quickly. Only 3% of the people in PNG are receiving any treatment at all for hyperglycemia, so there's pretty out of control diabetes, and they're transitioning from acute sort of infectious disease, which was really the majority of their problems 25 years ago, to chronic disease, because diets have changed. There's a lot more white rice, a lot of coconut being eaten, and a lot of starchy root vegetables. A lot of potatoes have made it in, and they're easy to grow and they're cheap. All right, so diabetes in the eye. I worked at the uni for 5 years, and they drilled into us that we have to do sort of learning outcomes at the start of the lecture, so I can't break that. So this is what I'm going to talk about. Because I know that I'm talking to a range of health professionals, I'm going to give a little bit of an intro into the anatomical background and the spectrum of eye disease, and then mostly I'll talk about diabetic retinopathy. I'm also going to talk about the diabetic eye examination that patients go through, because I know as an optometrist I get a bunch of questions from patients about other health professionals, and we do all live in our silos, and so when patients ask me about physiotherapists or podiatrists or dietitians, most of the time I have no idea what they do and what to expect from the patient's perspective. So I'll try and clear that up a little bit, and then we'll have some questions at the end. All right, so who is an optometrist? So an optometrist is a primary eye care provider, so patients can walk in off the street. They don't need a referral from anyone. It's obviously a university course. Generally speaking, we're fairly attainable. There's generally not waiting periods for appointments. And generally speaking, optometrists have very good relationships with the local ophthalmologists. So if you've got patients that have eye problems, and even if it is probably going to be a surgical treatment required, oftentimes the fastest way for your patient to get there is via the optometrist. Because a patient comes in with, let's say, a retinal detachment, we can call up the ophthalmologist and go, hey, this person's got a retinal detachment, they're going to turn up at 8 o'clock tomorrow morning, sorry. And that's what the ophthalmologists expect. If they go via the GP, it's really hard for a GP to be able to write out that referral effectively for the ophthalmologist to understand just how urgent that is. All right, and more than half of us can write prescription for topical medication. So really, most eye disease that's non-surgical, we can treat. In the diabetic realm, we can't actually treat much, but in saying that, about 95% of diabetics actually don't need surgical intervention for their eyes. They need monitoring and obviously referral when required. All right, so if you ever want to irritate an optometrist, ask that question. Don't you guys just sell glasses? And I'm sure every other health profession has exactly the same question that irritates the hell out of you. And look, I'm going to break some myths. Glasses aren't actually all that technical. Okay, so this is the 5-year course down at Flinders that I taught a whole bunch of different things in there. You don't need to worry about any of the words, but what I wanted to show was these topics in red were the topics that majority of the learning was about glasses and contact lenses. The ones in orange, The ones in orange were probably about 50-50. A big chunk of the topic was about glasses and contact lenses. And all the rest was about health and disease, because that's complex and difficult and changes, and you have to understand research, and the ands keep going. Okay, so the vast majority of our time is spent teaching people how to look after disease. All right, anatomical introduction to the eye. This is obviously a cross-section through an eye vertically, essentially. At the front, you've got the cornea, the clear window at the front. In behind that is the iris, the coloured part of your eye. And behind that is the lens. Now, this lens is what changes shape to allow you to see far away and up close, that dynamic capacity. And that's the one that over time becomes stiffer and harder, okay? And most people experience that in their early 40s, okay? And that's that needing reading glasses. And so that's what's happening when people are struggling to see up close. I hate to break it to you, but it will happen to every person on the planet. There's just no avoiding it. So if you hear of someone's uncle who's 72 and doesn't need reading glasses, he either can't see far away or he can't see up close. I haven't actually seen the patient that miraculously has everything, okay? The only other, and I should put a little asterisk there, the only possibility is that they have one eye that's good for far away and one eye good for up close. And they're pretty rare. They've struck gold and they don't know how lucky they are most of the time. All right. And diabetes, and I'm sure this is the case across the rest of the body as well, really affects just about every structure. So cornea, iris, lens. Now, aqueous, the aqueous, I didn't actually talk about it. That's the fluid in the front third of the eye. Okay, so it's produced back here where these little ropes are called zonules, flows out through the iris into the front chamber of your eye and then out through the angle between your cornea and your iris. That changes, and then obviously further back in your eye, it actually affects your vitreous, choroid, retina, optic nerve, and obviously, as Dr. Tan went through, blood vessels are very heavily affected. So what happens, and what will you hear your patients complain about with their eyes? You'll hear them talk about blurred vision. Now that can be a couple of things, okay? The big one is refractive change, and you would have probably heard a lot of patients talking about when their glucose levels move around, their vision changes. Okay, they have a change to how they see, and that's a relatively short-term change. We'll talk about that. Premature cataract formation, epithelial erosions. These are painful eyes on waking, but their eye looks pretty normal, and they should be able to see normally. Is increased. Cranial nerve palsy, so people turning up with double vision. Very, very upsetting for the patient. It's very difficult to live with double vision. And then diabetic retinopathy. And the important thing to realise there is that in the vast majority of the severity of the disease, there's actually no symptoms at all until it's quite severe. Not always, but often. All right, so refractive change, what's going on? Well, that fluid that I was talking about, the aqueous, that actually changes in osmolarity when the person's glucose levels change, and that changes the gradient between the aqueous and inside the lens. And so the lens actually changes shape as fluid moves in or out of the lens. Most of the time they become short-sighted. Oftentimes they can see better up close, but their distance vision has dropped away. It can happen relatively quickly, come on pretty quickly. It occurs over days to weeks. The problem is, even if you fix the glucose levels, it can take months to calm back down. And that can be a real problem for us because we can make their vision better in the distance, but it might only be good with that new pair of glasses for a month. And then it'll be different again, and then another month, and that becomes really expensive for the patient. Premature cataract development, I'm here busting a whole bunch of myths. If you're lucky enough to live long enough, you'll get cataracts. Okay, it's a bit, I liken it to osteoarthritis. Some people get it later in life and some people get it earlier in life, but most of us end up with it somewhere along the lines. Okay, and this is where the lens inside the eye becomes cloudy. Okay, you probably don't need to be an optometrist, so this is a dilated eye that's had some drops in there. And you can see, and this is light coming in from my side, or the right side, and passing through that lens. You can see that that's quite yellow. So that's what that person is looking out through as well. So that's what a cataract is. This one over here is slightly different. This is called a cortical cataract with all these spokes coming in. So this is actually, well, certainly according to this study anyway, the most common, what was their wording? Most common ocular diabetic complication. Now, it doesn't get much time compared to diabetic retinopathy because the treatment is exactly the same as for non-diabetics, and that's surgical extraction of that lens. So the ophthalmologist goes in, chops that up, takes it out and puts a plastic lens in. So this lens, this eye here has had a cataract surgery, okay? So it comes on earlier in diabetic patients, and so they end up needing cataract surgery earlier. That's really not too bad of an outcome, to be honest, because most people end up going through cataract surgery anyway. It's just a bit earlier. Epithelial erosions, and I put this in because it's really, really bad for the patient, but actually not that bad of a disease. That's where the cells that hold down the epithelium on the surface of the cornea change in diabetics, and that adhesion is less. And what can happen is when they're asleep overnight, their eyelid, and it happens to all of us, essentially dries out onto the surface of the cornea. And when they wake up, and we've all probably experienced it going, wow, my eyes are pretty dry, it actually pulls the epithelium off the surface of their cornea. And this here, we'll go back. This here is a little patch of epithelium that's been dragged off. Okay, the problem there is just under the epithelium is a lot of the nerves in the cornea, and so it's really, really painful. Okay, the cornea is very well innervated. The treatment is just lubricating drops. If it becomes really bad, PTK is where they basically laser off all of the epithelium and basically make the body start again. Okay, but you know, conservative treatment first is usually the way to go. All right, cranial nerve palsies, a little bit rarer, but certainly distressing for the patient. So this is where essentially the nerve to one of the muscles around the eyes has had a microvascular complication, and say with this lady here, she's trying to look to her left over this side, but this eye here just won't look left. Okay, and that's because the muscle on the outside of her eye, the lateral rectus, is innervated by a single cranial nerve, and that's the sixth nerve, and it just doesn't work at all. So every time she looks to her left, one eye goes and the other eye doesn't. And because her brain's not used to that, she gets two images of the world moving around. Okay, so getting downstairs, movement, mobility becomes really, really difficult. It happens quickly, generally in diabetic complications. There's no real treatment other than patching the eye in the short term. So oftentimes the person just ends up with a patch over their eye. What's this guy at the top got? This guy's also got a sixth nerve. So you can see when he's looking to his right, he can look, both eyes are pointing in that direction. And then when he looks to the left, this eye is looking down here and this eye is just not looking out at all. Okay. This guy down here has a much more worrisome nerve palsy. That's a third nerve palsy because the third nerve also controls eyelid retraction. And just because of the anatomy, that can be associated with much more serious complications. All right, so let's get to the back of the eye. These are both healthy, normal retinas. Okay, if you've seen retinal photos before, great, but I am going to describe a little bit. So this is the optic nerve at the back of the eye. This is basically the end of the data cable between the eye and the brain, and out of the middle of there comes all the vasculature for the retina, or I should say the inside 2/3 of the retina. is supplied by these blood vessels. The slightly lighter vessels are the arteries, and the slightly darker ones and slightly larger vessels are the veins. The nice thing about an eye is that there's not many other places in the body where you can see the blood vessels quite like this. Okay, they're sitting right on the surface, basically waving at you. And so obviously you can see complications fairly quickly, as opposed to a foot, where you've got to use ultrasound or nerve conduction studies and blah, blah, blah. We just look. We're pretty simple. You'll notice that there's a difference between this eye and this eye. This would be a fairly lightly pigmented person, and this would be, this is a fairly dark pigmented person, because there's a layer behind the retina that is associated with how pigmented you are. Your eye will be just as pigmented. So both totally normal. This eye's, that eye's a little X-silo torsion. Just rotate a little bit, that's fine. It's important to recognise that these are the photos most often that we look at, but this is actually only a small portion of the retina, and even this photo doesn't actually cover the whole retina. Okay, so the photo that we saw before was sort of just this bit here. Okay, all of these bits out here are also really important for making sure the person doesn't have diabetic retinopathy or treatable disease, really. All right, diabetic retinopathy, most common cause of blindness in working age adults. For the most common cause of blindness is actually macular degeneration, but it happens much, much more commonly in much older people. So certainly economically, diabetic retinopathy is a massive problem. Blindness is a problem always, but it's a breakdown of the blood-retina barrier. It's generally asymptomatic until quite severe, and the person will get essentially patchy vision like this. Now, if they've only got patchy vision like that in one eye, the brain's really good at putting the two images together and filling in the gaps. So even if their other eye has other patches missing, they often don't notice. Okay, because we look at this photo and go, oh, that would be easily seen, but the brain's actually good at filtering it out. So this eye over here, I don't think you need to be an optometrist to recognise that there's some disease there. This person would not have any symptoms at all. They would be saying that their vision is totally normal, totally fine. And look, that's a guess, because this is edema that's coming pretty close to the centre of their vision, but I don't think it's affecting their central vision. All right, so what are we looking for? The first thing that happens is you actually get pouching of the capillary bed. Okay, we call these microaneurysms. They just look like the tiniest red dots in the retina, and they're the first signs. Even if there's a few there, if you actually do a fluorescein angiogram, you'll actually see a lot more hiding. So you can't see them all, but it's the first signs. And then obviously you've got hemorrhages. This here, this white area, the other nice thing about eyes is it tells us when there's a part of this is nerve fibre layer that's ischemic. Okay, so this is a ischemic nerve fibre layer, and conveniently it goes white to tell us that it's ischemic. And this yellow area here is actually edema, so swelling within that retina. So if you look at it in 3D, it'll be like a little blister there. All right, now diabetic macular edema is the most common cause of visual change. So once the person gets this is when they'll actually start saying, you know what, I can't see that well in this eye. It's important to recognise that often their vision isn't terrible, okay? It's dropped off by a line, 2 lines, sometimes more, but it doesn't have to be awful vision. It can be fairly subtle. And that's because, so this is edema away from the centre. So this area here without the blood vessels over the top is called the macula, and that's the centre of the back of the eye, central vision. If there's edema away from the centre, you're not going to have any effect really at all, but once it starts to encroach on the macular centre, the person will have vision change. This is best assessed, and when I say stereopsis, when I'm looking at a patient through a slit lamp, so that's the thing where the patient puts their chin on and they put a bright light on, the advantage is I can look in with both of my eyes. So I can actually see that raised, so I have 3D vision when looking at the back of their eye, so I can see that blister, okay? And optical coherence tomography, so this is, since I graduated, it's not that new now, but it's a fairly advanced piece of imaging, and it's very, very common now. And this is an optical coherence tomograph, I guess, of the centre of the back of the eye, that macular area. And this is a healthy, normal macula. You get this lovely little dip. And these are the different layers of cells within the retina. Okay, so this imaging goes down to the layers of cells within the retina. And along the bottom here, this white line, we call it the integrity line, basically indicates the rods and cones. Okay, so people have probably heard of rods and cones. They're the cells that actually sense light in the retina, and they actually sit on the bottom. So the light has to pass through the rest of the retina to get to the rods and cones, and then the information actually goes back up through the retina, through bipolar cells, and then onto ganglion cells. Normal, abnormal. Pretty easy to see in an OCT. So that would be that little blister that I was talking about. You get these fluid-filled spaces. And obviously the information from these rods and cones will not make it back to the brain in a normal way. Everything gets disorganised. And the sad thing about it, I guess, is even if you can control that and get that to go back down, it never quite goes back down the way it was. Okay, the organisation just gets messed up with that edema. The vision gets better, but not quite as good. And this is this was one of my patients, fairly significant diabetic retinopathy. You've got the edema over here and probably over the macula, lots of hemorrhaging. And over here, I would say that's actually maybe a little bit of neovascularization, so angiogenesis, new blood vessels growing in that area here. I'm not sure they would be. They might be what's called Irma, so they're collateral vessels. The only way to tell the difference definitively is with an angiogram, or if they're leaking. So neovascularization, new vessel growth in response to Veg F and ischemia, and Dr. Tan's probably squirming because it's a little bit more complex than that. But in our world, that's sort of as important, as deep as we need to go. And this is just, I mean, it's beautiful, the new vessels growing. The problem is they're pretty average, well, they're pretty poor vessels. They're fragile, and this will eventually, now obviously it didn't because that's a left eye and that's a right eye, but this will eventually turn into this, okay, where those blood vessels will leak, and that's a vitreous hemorrhage. Basically the blood will spill into that back chamber of the eye and go from, again, this, amazingly, often these people have pretty normal vision until this happens, and then they have no vision at all, okay? And this is the worst, probably, outcome of diabetic retinopathy, where you get scarring within the vitreous, usually after they've had a vitreous hemorrhage, and this is fibrovascular connections to other parts of the retina that can actually drag the retina away. I'm not trying to scare you, but that's why we want to jump in with treatment, to get it back before any of this starts to happen, because this is much harder to deal with. All right, so management, what do we do with diabetic management? And I wanted to talk a little bit about the past, because you'll still get lots of patients with these things that have happened to them, and you'll hear them talking about it, the current, and what are the possible future treatments, and what are the challenges that I see, and that's why I was excited to hear Dr. Tan's lecture. Is our treatments at the moment are a little bit, they could be better. There's room for improvement. So in the past, when people got that macular edema, they used to get grid laser, and that's where the ophthalmologist would aim a what's termed a sub-threshold energy level laser at their retina. So the aim isn't to burn it, the aim is to just essentially upset the pigmented layer underneath the retina enough that it actually upregulates. So if you send a subthreshold laser at the pigmented layer under the retina, it'll actually upregulate what it's doing. And the RPE, or the pigmented layer's role, is to try and suck back in and mop up all that edema. So it seems like a pretty good therapy. The only problem is sometimes you did get atrophy. There was enough energy to cause cell death, and sometimes you used to get what's called, or you still can get it, creeping atrophy, where there's a small part of dead cells and that progressively over time gets bigger. So there was risks associated with it. Then people started talking about anti-Veg F treatments. And the sort of landmark study was the RESTORE study, which put grid macular laser to bed, and they compared grid macular laser with anti-Veg F injections, and what they found was that after 12 months, 24% had 612, so that's legal limit, that's the limit to drive after 12 months, versus anti-Veg F, which had 53, or if a combination therapy of anti-Veg F and laser was only 45%. So the laser wasn't really helpful compared to the anti-Veg F, though these two numbers here weren't statistically different to each other, but both of them were statistically different to the laser alone. Really the meaning of that is laser bad, anti-Veg F good. But it's never that simple, right? The problem with the anti-Veg F, and I'll go back, is that it's an injection into the eye. Doesn't sound like much fun, right? And also it doesn't last all that long. The grid laser, you had an effect that lasted much, much longer. And so if you have patients that don't want to come in regularly or can't come in regularly or stridently do not want an injection into their eye, grid laser is better than leaving it alone. So it still does occur sometimes, and when I was working in Central Australia, those situations came up a little bit more. People that just refused to come into town that often, and this is a treatment that can be once off or maybe twice, and you get an effect that lasts for years. Present treatments, so pan-retinal photocoagulation. This is like suprathreshold laser, and it aims to, so you've got retina that's ischemic releasing Veg F, okay? You can stop that by killing the retina. That's basically what pan-retinal photocoagulation is. It's lasers applied to the peripheral retina, basically sacrificing it and saying, look, if we stop all this retina releasing Veg F, the person will at least retain their central vision, which enables them to see their family and maybe drive, depending on the circumstances. But I think it's fair to say that we would all recognise that maybe this isn't the most sophisticated treatment for a disease. But it works, so that's okay. The downsides, obviously you lose peripheral vision, but you actually also lose a little bit of colour vision, your night vision changes, and you lose what's called contrast sensitivity. I'll talk about that a little bit more, but it's quite important. So contrast sensitivity, we all know the Snellen chart that sits at the end of our GP's room or the optometrist room, right? Black letters on a white background. Now, the important thing to recognise there is that that's not the world we live in, okay? Very rarely are we looking at black writing on a white background, and it doesn't really tell us often about how someone might be able to navigate through the world. So something like walking down a grassy hill can be really, really important, and there's no black letters on white backgrounds, and it's a much larger stimulus, okay? So this is one way to measure contrast sensitivity. This is called a Pearly Robson chart, and it's the same size letters, just getting dimmer. Okay, and the results can be very different for different diseases. You can put this chart at different distances to measure different size stimulus. And so try not to get too technical, but this is contrast sensitivity. So these higher bits of the graph are people that can see less different between stimulus and background. Okay, so dimmer letters. Okay, and along here is spatial frequency, so letters getting smaller. Okay, so down the bottom here is black letters on white backgrounds, and this is really small letters. So when we're measuring visual acuity, all we're doing is measuring this spot on the curve of how people see. Okay, now this line here, D, is refractive error. So people who are short-sighted actually have fairly normal contrast sensitivity at larger spatial frequencies. And I feel like I'm talking a little bit too technically, but what it means is without glasses on, people with just refractive error can actually navigate okay. They can walk around, they can see people, they can see chairs in the way. They just can't see small stuff or stuff that's too far away. It's important to recognise that that's actually very different vision to someone who might have exactly the same visual acuity on a chart, that might have, let's say, multiple sclerosis, and as it turns out, oftentimes after they've had pan-retinal photocoagulation. So their visual acuity on a chart can be completely normal, and they're still complaining to you about not being able to see steps and things in life. And you're going, yeah, but you can see the chart, okay? And this is the reality. And cataract kind of affects everything, okay? So it's important to realise that that number, even though that's how we judge whether people can drive and basically it's the only thing we rely on, that's probably just because that's what we've always been doing, and it's probably not the best marker for how well people can see. All right, so present treatments, I probably should have warned people. This is an anti-Veg F injection going in. Okay, it goes in just behind the coloured part of the eye. So that's a speculum to hold their eyelids. They would have had an antiseptic wash, some anaesthetic, and in it goes. It can be pretty uncomfortable and very daunting for the patient. Generally, people with diabetic macular edema, they're looking at monthly treatments in the first period of time. Okay, so they've got to not only turn up once, but they've got to turn up 4 weeks later, and 4 weeks comes around pretty quick when someone's going to stick a needle in your eye. Oftentimes it's used in conjunction with PRP for proliferative disease. This is the mainstay for treatment for diabetic retinopathy now. It is costing the government a fortune, just amazing amounts of money. So, and you know, that's okay because it's really good at stopping eye disease, and eye disease is really expensive too. So, you know, they get their money back. But each of these injections costs the government around $1,500 to $1,700. Every diabetic patient that's getting injected is getting them every month. You know, so those on this treatment often get it monthly for a year, 18 months. So if you do the maths, it's really high. It's also the same treatment for neovascular age-related macular degeneration. I was talking to someone yesterday, there's an ophthalmologist in Brisbane that does 70 to 80 of these injections in a morning. Okay, so he's going through $120,000 worth of PBS drugs in a morning, and then heads off to clinic for the afternoon. Okay, so and that's one ophthalmologist. This is across the country. So amazing amount of money. So if we could find something else through Dr. Tan, that would be awesome. So possible future therapies, and I'm not going to spend too much time on this because it's not my area of expertise, to be honest, but novel non-Veg F cytokine modifying treatments. So Veg F is like the end product of ischemia. Okay, this is your body going, like this tissue is dying, I need new blood vessels. But to get to that point, there's a whole bunch of other stuff that goes on, and can we modify other things before then? Okay, hopefully the answer, because VEGF, you've got to have ischemia and you've got to have enough ischemia to get the VEGF. So you're kind of dealing with the end product. You're kind of just trying to mop up the end rather than fixing earlier on. The trouble with eyes is that, and intravitreal injections, if we could get anti-VEGFs in another way, that would be also probably very, very beneficial for the patients. The trouble is, eyes are pretty well designed to keep stuff out. Okay, so even just looking at the cornea here, okay, the top layer, the epithelium, is a whole bunch of phospholipids, so they're very polar and designed to keep out anything water-based. And then the next layer is the stroma, which is almost entirely, non-polar. The stroma is almost entirely polar, trying to keep out everything non-water-based. Okay, so getting a drug through there is relatively difficult, and then all you've managed to get to is to the front chamber of the eye. You've actually got to pass through the rest of the eye to get to where the problem is in an eye. So topical treatment for these diseases is going to be really difficult, but there's people working on it. I would be much more interested in systemic treatments that change angiogenesis or the pathways even before that, because to be honest, what's happening in the back of the eye is happening elsewhere in the body. So if someone's got diabetic retinopathy, you can guarantee that they've got other changes elsewhere in their body. I don't investigate it, I send them on to other people. Okay, however, and I just wanted to say, to be honest, control is key. Before that happens, the biggest changes, so these are old studies now, and DCCT and EDIC were type 1s, UK-PDS was type 2, and compared conventional at the time versus intensive control. And intensive control reduced diabetic retinopathy a really, really large amount. Probably better than our treatments, to be honest. One thing that I wanted to bring up that isn't all that well known is, and I'm not sure if it happens in other parts of the body, I've never actually looked it up, I probably should, is that those who went on to intensive control, 13.1, and these were the type 1s, 13.1% actually had a short-term worsening of their diabetic retinopathy. And this can be really devastating psychologically for a patient that's just gotten their life together in terms of treatment, and then they come in and see me and I go, actually, your eyes have gotten worse. Okay, so I have to be careful in how I coat that, but also it's important for the rest of the healthcare team to understand that that's pretty common, and if the most common is going on to insulin for type 2s that have been hesitant to go on to insulin, I want to see those patients that suddenly have gotten their control really good. Okay, because 13.1% of them will have a short-term worsening in their retinopathy. So if I can get a letter from a GP or whoever, I don't mind, because I don't need a referral from anyone saying, look, this person's just gotten their control together and it's gone really well. Do you mind having a look at their eyes? And I'll be like, hell yes, that's fantastic. And hopefully we go, yeah, look, it's looking good. I'm going to see you in 6 months, and by then things hopefully your control's still going well, and you're through the short-term worsening phase, and off we go. But I would recommend another check there. Sometimes people worry about whether they're going to get a Medicare rebate if they get sent down to their optometrist at different times. Don't worry about that. Okay, for diabetics, if it's clinically justified or justifiable, they can get seen every 2 weeks. Every week if you could justify it clinically. Okay, there's an item number specifically for diabetics, and there's no time frame on it. Okay, provided, and it does have a stipulation, provided they get drops in. Okay, basically Medicare said if you're not getting the drops in, it's not a good enough diabetic check, so you don't get the rebate. I'm cool with that. So they'll end up with getting drops for their examination, but that's okay. So don't be scared about that. Diabetics kind of get free rein because it's much more expensive to look after someone that's had vision loss than it is to pay for an eye check earlier on. It's just a good investment by the government. All right, so what should your diabetic patient expect, or what should you expect if you're diabetic out of your eye checks? So in addition to the normal testing, obviously we'll check your VA on the chart that I just bagged out as not being the best way of checking vision, but we will do it. And refractive error, flick some dials. For the diabetic patient, the things that we should ask about is how long has the person been diabetic? And we love it if the person knows their HbA1c because it allows us to profile their risk. And really it doesn't change the process of the examination, it changes how long I'm going to leave that person before checking them again. Someone with no diabetic retinopathy and a HbA1c of 6.5, I'm probably not going to need to see them at least for 12 months. Okay. The same patient with no retinopathy but has a HbA1c of 12%, I'm going to be much more uncomfortable about leaving them. 5 minutes? Okay, cool. Much more uncomfortable about leaving them for the whole year. And we've actually got really good stats. The ETDRS study gave us stats about what's the percentage risk of someone moving from each level of retinopathy through to high risk or vision threatening retinopathy. So we can generate pretty good numbers around what's the likelihood of someone becoming having vision problems. The problem is that it's pretty old now and the world's moved on in terms of treatment. Dilation, I talked about the drops. So what the drops do is they're a parasympatholytic drug, anticholinergic agent, that the neurotransmitters for the sphincter muscle and the radial muscle are actually different, and that's great for us because we can knock one out and leave the other. So what the drops generally do is paralyze the sphincter muscle temporarily, and the radial muscle, just unopposed, you'll end up with a pupil like that. Makes my job a whole bunch easier. Looking into the retina, it's kind of like looking through a keyhole. The bigger the hole, the better I can see. I can see through with both eyes and I can see further around. Obviously a normal eye and a puppy that either has had pharmacological dilation or some issue with their iris, but I just thought he was cute. Looking at the back of the eyes, I guess the only thing to take out of this is direct ophthalmoscopy. Look, if you guys have had a chance to use them, they're bloody hard to do just about anything with. Down at the university, we call them guessing sticks, because there's a couple of things. First up, you've got to get really, really close to the patient, and you can only see a really small part of the retina. So when you're looking through a direct ophthalmoscope, you can basically see the size of the optic nerve at any one time. Okay, and if we remember back to that whole retina, that's a tiny proportion of the retina. So it's kind of like searching for a friend in a crowd through a telescope. Okay, you've just got massive magnification, so you can see the bit you're looking at really well, but you just don't know where you are, and you can't tell if you've seen all the bits. Okay, this is what is probably the best. So this is through a slit lamp, and that really doesn't give justification to it, in that when I'm looking through with the slit lamp, it's kind of like looking at a flower in the flesh versus looking at a photo of a flower. You can see things much more clearly. You can even see, oftentimes you can actually see the person's heart beating with the vein pulsating there. So this is this bad, this good. So people should expect that. Retinal photographs, well, I didn't actually finish that sentence, and it's not a very good one. It's only really appropriate as a screening tool. Okay, if someone's got a small amount of edema or something like that, it will get missed on a photo. It's just as simple as that. That's what the research says as well. Additional imaging, optical coherence tomographers are great, and these are retinal photos. This is the difference between a photo with an undilated pupil, okay, versus a dilated pupil. So even a retinal camera, this is actually just the edge of the pupil as the photo's going through. So you get washed out edges. What they should expect, to have their pupils dilated, the vision will be affected for around 2 hours. The sun will be really strong. The vision will be not quite as clear for 1 to 2 hours. It's best if the patient doesn't drive, although that's really up to the patient. Okay, if the patient chooses to drive, they can take on their own responsibility there, and sunglasses will definitely be preferred. I've had my pupils dilated probably 400 times because that's how we practice on each other down at the university, and practice on me, and the vision isn't too bad, okay, most of the time. It depends also on the person's refractive error and a whole bunch of other reasons about just how bad it'll be. They should have communication back to the primary care physician, generally the GP or an endocrinologist. That communication is really, really important. It doesn't need to be long. Generally mine are like 3 lines. I saw Mr. Jones. He has no signs of retinopathy. I want to see him in 12 months. That's all they want to hear. They don't want to hear he has lovely brown hair. So for you guys, everyone gets questions, and I mentioned this before, about other professions, and oftentimes I've got no idea how to respond. Regular eye examinations, look, the recommendation really for at least yearly for anyone with current retinopathy or anyone who's Aboriginal or Torres Strait Islander, they just have increased rates of diabetic retinopathy. Anytime there's a change in vision or pain or discomfort, and any significant change in glycemic control, I want to see them for better or for worse. So oftentimes when someone ends up on steroids or something for another reason, often their glycemic control goes haywire. I don't want to see them that week because they've got other stuff going on, but soon after I'll want to see them as well, probably along with every other health professional they have. If they can know their HbA1c, that's awesome. And like I mentioned before, if the person's complaining about vision things and they said, yeah, but I saw my optometrist 3 months ago, reassure them that don't worry, there's a Medicare item specifically for diabetics, and if you've had a change, you're good to go. Don't stress. If they're turning up every month to me just wanting another eye test, Medicare won't be happy with that, and that's fine. As a taxpayer, I'm cool for them to be turned down, but if there's any change, they're always happy.
Thank you, Ben.